Heart failure, left-sided and right-sided. Manifestations, signs and symptoms, early and late signs. Left-sided, signs and symptoms. Dyspnea, rales, orthopnea, weakness, nocturnal paroxysmal dyspnea, increased heart rate trying to get blood to organs, nagging cough, frothy and blood-tinged sputum, gaining weight most common in left side. Right-sided, swelling of legs, hands, liver, weight gain, edema, pitting, large neck vein, distended jugular vein, lethargy, irregular heart rate, AFib, nocturia, increased girth. Potential complications. What can go wrong? Common versus severe. Faulty heart ducts, valve stenosis, regurgitation, inspection, heart works very hard, making weak, arrhythmias, AFib or tachycardia, infarction, myocardial, CAD, muscle dies, lineage, congenital, family history, uncontrolled hypertension, stiffen of heart wall, recreational drugs, cocaine and alcohol abuse, evaders, virus or infection that attacks heart, cardiomyopathy, valvular heart disease. Who is at risk? CAD, hypertension, and previous heart attack is those that are at risk for heart failure, left-sided and right-sided. Diagnostic labs, BNP, sodium levels, potassium, albumin, creatinine, chest x-ray, EKG, echocardiography, exercise stress test, MUGA, cardiac cath, and MRI. Nursing interventions or treatments. Labs, potassium, BUN, creatinine, digoxin, BNP, tropins, high fallers to help with breathing. Safety, orthostatic hypotension and swelling. Increased falls. Low sodium diet, 2 to 3 grams a day. Fluid restriction, 2 liters a day. Vaccinations, flu and pneumonia. Aerobic exercise. Daily weight, less than 2 to 3 pounds daily. Smoking cessation, limit alcohol. Early signs of heart failure. Shortness of breath, orthopnea, weight, shortness of breath, orthopnea, weight gain. Medication. Always administer medications before ventricle dies. ACE inhibitors. Pril, PRIL, beta blockers. LOL. Digoxin, ARBs, angiotensin II receptor blockers, which are sartans. Loop diuretics, which is IDE. Potassium-sparing diuretics, which is ON. Vasodilators, atrial dilator, hydralazine. Intraprofessional care, cardiologist, nutritionist, therapist. Patho background information, CAD, hypertension, previous heart attack. Discharge planning, heart healthy diet, exercise, manage stress. Other information. Left side, left ventricle diastolic dysfunction, filling and resting, ventricle too stiff to allow normal filling. ACE inhibitors, Pril, first line of treatment, prescribed with beta blockers, lisinopril, block conversion of angiotensin 1 and 2 vasodilation, decrease blood pressure, kidney excrete, sodium decreases aldosterone. Side effects, increased potassium, dry nagging cough, decreased taste. Loop diuretics, used in combination of ACE or ARBs, decrease water, decrease sodium, decrease chloride, decrease edema, which then causes urination. Monitor digoxin, lithium, and anticoagulants. Decrease potassium, decrease sodium, decrease chloride, decrease calcium, orthostatic hypotension, toxicity. Beta blockers of LOL, blocks norepinephrine, negative inotropic effect to decrease contraction, decrease heart rate, and decrease workload, decrease heart rate contraction, and use in specific forms of heart failure along with an ACE or ARBs. Stable systolic and dysfunction treats diastolic dysfunction problem with filling so heart can rest and fill properly. Side effects: decreased heart rate, masks hypoglycemia, no grapefruit, not for COPD or asthma. Potassium sparing diuretics, which is the ONE, like spironolactone, used in combination of ACE or ARBs, decrease water, decrease sodium, decrease potassium, decrease edema, urinate. Loop decreases potassium. Potassium sparing increases potassium. Watch if taken with ACE or ARB. Side effects: nausea, vomiting, diarrhea, photosensitivity, anemia, headache. Amiloride, hydrochloride, trimethoprim, vasodilators, atrial dilator, hydralazine, used sometimes if patient can't take ACE or ARBs. Vasodilation of arteries and veins, decrease blood, fluid going back to heart due to decreased workload. Side effects: hypotension, orthostatic edema, reflux tachycardia, palpitations, dioxide, NTG, and nitropuricide. Digoxin positive inotropic increases heart ability to contract. Stronger negative chronotropic cause heart to beat slower, allows to hear rest and pump more blood, not first line of treatment. Used with ACE, diuretics, used in left ventricular systolic dysfunction. Side effects: decreased heart rate, visual disturbances, fatigue, weak. Therapeutic range is 0.5 to 2.0 ng per deciliter. ARBs, angiotensin 2 receptor blockers, sartan. Used as in place of ACE inhibitors. Example: lysartan blocks angiotensin 2 receptors. Vasodilation decreases aldosterone. Side effect: increase potassium. Digoxin toxicity increases chance of hypokalemia. Check apical pulse before given. Toxicity: signs and symptoms: anorexia, nausea, vomiting, diarrhea, then heart rate abnormality and visual disturbance appears yellow-green halos. Dysrhythmias. Peripheral vein disease, PAD, and CVI. PAD, manifestations, signs, and symptoms: intermittent pain, cramping with activity, intermittent claudication, rest, pain, burning sensation in legs, numbness, decreased sensation, diminished or absent peripheral pulse, foot polar with elevation, elevation polar, reactive hyperemia, extremity dark red when dependent, thin, shiny, and lack of hair on skin, thickened toenails, skin areas of discoloration, skin breakdown. Potential complications: what can go wrong, common versus severe. PAD, higher risk of mortality. PAD is a marker for advanced systemic atherosclerosis, gangrene, limb amputation, wound infection, sepsis, uncontrolled pain. Who is at risk? Those with PAD, hypertension, hypercholesteremia, hypertriglyceridemia, hyperlipidemia, diabetes, CKD, hyperuricemia, tobacco use, familial predisposition, 60 plus years old, obesity, sedentary lifestyle, stress, elevated C-reactive protein, PAD, increase with Raynaud's, cold stress, and burgers, inflammation, clot formation. Diagnostic labs: PTA, PTBA, PTA, and cold therapy. Peripheral artery bypass surgery, endarterectomy, mechanical clot extraction therapy, sympathectomy, amputation. Nursing interventions of PAD and CVI. The vascular: elevating legs to decrease edema and increase blood flow. Monitor for blood clots, anticoagulants, and compression stockings. Peripheral: legs down in dependent position, helps pain. Avoid tight clothing and shoes. Avoid extreme temps. Quit smoking. Avoid crossing legs. Omit anticoagulants, antiplatelets, walking program. Decrease cholesterol, low-fat diet. Incentive spirometer, bypass surgery, NPO for first pre-op day, then clear liquids. Increased arterial perfusion, Monitor blood pressure, minimally invasive, ambulatory, and eat within the first post day. Medications. Sildenafil increases blood to extremities. Pentoxyphyline decreases blood's viscosity, increases red blood cell flexibility. Aspirin, Plavix. ACE inhibitors, Rampapril. Statin, simvastatin. Fibric acid derivative, Gemfibrozil. Antioxidant nutrients, vitamin C, vitamin E, garlic supplements, traditional Chinese medicines. Intraprofessional, stress testing, Doppler ultrasound, transcutaneous oximetry, angiography or MRI, ankle brachial index, diabetes contraindicated. Patho background information for PAD, deposit of cholesterol and lipids when the vessel walls gradually thicken at the intima and media, progressive narrowing of the artery, obstructed decreasing blood flow to the lower extremities, tissue apoxia or anoxia results. Since symptoms once vessel is occluded by 60% or more. Discharge planning, tobacco cessation, maintain an ideal body weight, proper footwear, monitor blood pressure, monitor blood sugar, hemoglobin A1C, diet, hypertension DASH, diabetes ADA diet, and regular physical exercise. Additional information classified as atherosclerotic aneurysm and non-atherosclerotic vascular disease, divided into coronary, cerebral, peripheral, mesenteric, and renal artery disease. PAD and highest rates, thickening of artery walls of African Americans, lower socioeconomic status, women, affects the iliac, femoral, popliteal, tibial, and peroneal arteries. Femoral, popliteal most common in non-diabetics, and diabetes usually have it below the knee. Additional information, complementary health approaches, aromatherapy, biofeedback, healing or therapeutic touch massage, herbal therapy, exercise, yoga, or very low-fat vegetarian diet. CVI, common in older adults, ulcers, painful, slow to heal, debilitating, costly, affect daily of life. Thrombosis, obesity, chronically distended veins, damaged valves caused by prolonged sitting or standing. Thrombophlebitis, osteomyelitis, and malignant changes. Coronary artery disease. Manifestation, signs and symptoms, early and late signs. Atherosclerosis, endothelial injury and inflammation, soft deposits of fat that harden with age, chest pain, ischemia, angina, shortness of air, first symptom. Major cardiac event, anxiety, atypical in women, dyspnea, nausea, and weakness. Potential complications. Leading cause of death in the U.S. is coronary artery disease. Myocardial infarction. CAD is the lead cause of death in women, regardless of race or ethnicity. Who is at risk? Tobacco use. It increases LDL, decreases HDL, increases oxygen radicals, and increases carbon monoxide. Hyperlipidemia, hypertension, toxins, diabetes, hyperhomocysteine, and infection. CRP increase, chronic exposure to CRP, ages older, 45 and older for males, and older than 55 for females. Gender, ethnicity, especially African Americans, genetics, physical inactivity, obesity, stress, anger, depression, increased homocysteine level, pernicious anemia. Diagnostic test, hemoglobin A1C, lipid panel, monitor liver, especially with simvastatin or any statins, reassess after 6 weeks of therapy. Cardiac troponin, CKMB, myoglobin, CBC, C-reactive protein. homocytosine, PMB, creatinine level, EKG, chest x-ray, exercise chest, CTA, echocardiogram, CT scan, PET, coronary angiography. Nursing interventions, health promotion, stop smoking, prevention, identify people at risk, education, health promotion. Secondary, screening lipid panel, lipid management, antiplatelet therapy. Physical activity, at least 30 minutes with weight training 2 days a week. Frequency, intensity, type, and time. Decrease saturated fats and cholesterol. Increase complex carbs and fiber. Decrease red meat, egg yolks, whole milk. Increase omega-3 fatty acids. Decrease simple sugars and alcohol consumption. Eat tofu, granola, walnut, and flaxseed. Promote balanced nutrition, health maintenance, acute pain, tissue perfusion, effective cardiac perfusion, effective coping, manage fear. Medication, antiplatelets, antihypertensive, antilipidemic, fish oil, EPA, and DHA, supplements, B-complex vitamins, simvastatin, decrease LDL, increase HDL. Side effects, rhabdomyolysis, niacin lowers HDLs, increases HDL. GI side effect, orthostatic hypertension, gemfibrozole, increases HDL and decreases LDL. Bile acid sequestrants, drugs that decrease cholesterol absorption, Zeta, aspirin, Plavix, lisinopril, losartan, carvedilol, metoprolol, bisoprolol, ranitidine, nitroglycerin. Intraprofessional care, counselor, cardiologist, nutritionist. Patho background, injury to endothelium, C-reactive protein or CRP, unstable plaques and oxidation of LDL, cholesterol, collateral circulation, chronic ischemia, discharge planning. Relaxation techniques, set realistic goals, clarify personal values, educate nutrition, diet, exercise regimen, decrease exposure to pollutants or toxins, monitor blood pressure daily, maintain a healthy weight, elderly avoid extreme temps. Additional information. Acute coronary syndrome develops from sudden reduced blood flow to heart. Acute myocardial infarction, death of myocardial cells, occurs when blood flow to a part of the cardiac muscle is blocked, life-threatening. 60% of deaths are within the first hour. 40% before hospitalization occurs when blood flow to part of cardiac muscle is blocked. Stages of atherosclerosis. Chronic endothelial injury, damaged endothelium, fatty streak, fibrous plaque, complicated lesion. Management. Cardiac catheterization, coronary angiography, visualize blockage, open blockages, percutaneous coronary intervention, balloon angioplasty, stent. Cultural circulation is inherited predisposition to develop new blood cells. Presence of chronic ischemia, types of angina, predictable stress, exertion, silent ischemia, no symptoms, diabetic neuropathy, prinzmetals or variant angina, rare spasm of the major coronary artery at rest, microvascular angina, women daily activities, unstable angina, rupture of unstable plaque. Diabetes is a risk factor because it increases cholesterol, triglycerides, which cause endothelial dysfunction. Metabolic syndrome, insulin resistant, which can cause hypertension, obesity, abnormal serum levels, and increased blood sugar. Contributing factors, type A personality, depression, anxiety, stress, lack of support, high homocysteine level, breakdown of amino acids, B6, B12, lower homocysteine, and substance abuse, cocaine, and meth. Additional information. Garlic reduction of total cholesterol and LDL. Flaxseed, reducing risk of heart disease, diabetes, and stroke. Niacin, increased HDL. Omega-3, reduction of triglyceride levels. Psyllium, reduces total cholesterol and LDL. Plant sterols, reduction of total cholesterol. Red yeast rice, decreases reduction of total cholesterol. LDLs and triglycerides. In soy, moderate reduction in total cholesterol and LDLs. Mitral valve prolapse. Most common valvular disease, often asymptomatic unless severe and has regurgitation, mild systolic click, and late systolic murmur. Just pain, tightness, stress, syncope, tachycardia, palpitations related to dysrhythmias, fatigue, dyspnea, anxiety, depression, panic attacks. Murmur is between S1 and S2. There is a click sound. Both genders, symptomatic MVP and hyperthyroidism, and genetics. History, physical exam, CT scan of chest, EKG, chest x-ray, heart size rhythm, ischemia or ventricular hypertrophy, echocardiogram, valve structure, function, heart chamber size, heart catheterization, monitors pressure of the heart chambers, measures size of valve openings. Valve is flappy. Subjective assessment, past medical history, IV drug abuse, palpitations, fainting, angina, paroxysmal nocturnal dyspnea, history of rheumatic fever, infective endocarditis, congenital defects, heart attack, chest trauma, cardiomyopathy, syphilis, Marfan syndrome, strep infections, S3 and 4, heart sounds, hypertension, ascites, prophylactic antibiotic to prevent rheumatic fever and infective endocarditis, vasodilators, nitrates, ACE inhibitors, positive inotropes, digoxin, diuretics, beta blockers, sodium restriction, anticoagulation therapy, antidysrhythmic drugs or electrical cardioversion, cardiologist, therapist, primary doctor, percutaneous transluminal balloon, valvoplasty placed on femoral artery, valve repair, preferably or replacement, valvoplasty, annuloplasty, background information, notes, mitral valve, leaflets in the papillary muscles or chordae that allows the leaflets to prolapse or buckle back into the left atrium during systole, discharge planning, monitor INR, avoid strenuous activity for 3 to 6 months, discourage tobacco use, encourage compliance, teach patient when to seek medical treatment, excessive fatigue, anemia, dyspnea, healthy diet, avoid caffeine and stimulants, incision care, no MRIs, monitor signs and symptoms of infection, heart failure, or bleeding. Mechanical valves consist of a combination of metal alloys, paralytic carbon, and Dacron, more durable and last longer than biologic valves, increase risk of thromboembolism and require long-term anticoagulation therapy. Main risk is bleeding from the use of anticoagulants. Biological valves constructed from biovine, porcine, and human valve. Decreased chance of immune response and tissue rejection. Does not require anticoagulation therapy. Less durable. Early calcification, tissue degeneration, and stiffening of the leaflets. Gestational hypertension, signs and symptoms, no protein in urine. Preeclampsia has protein in urine. Begins after week 20 of pregnancy, elevated blood pressure of 140/90. Greater or different occasion at least 4 hours apart. Blood pressure returns to normal at 12 weeks postpartum. Placental abruption, kidney failure, hepatic rupture, preterm birth, and fetal and maternal death. Maternal age younger than 19 or older than 40 years, first pregnancy. Extreme obesity, multifetal gestation, chronic renal disease, chronic hypertension, familiar history of preeclampsia, diabetes mellitus, rheumatoid arthritis, systemic lupus, erythematosus. Diagnostic labs, liver enzymes, blood creatinine, BLN, uric acid, CBC, clotting studies, chemistry profile, 24-hour urine collection, non-stress test, contraction stress test, biophysical profile, and serial ultrasounds to assess fetus status, Doppler blood flow, analysis to assess fetal well-being, daily kick counts. Assess level of consciousness, obtain pulse ox, monitor ONI or INO, obtain daily weights, monitor vital sounds, encourage lateral positioning, perform NST and daily kick counts, magnesium IV, monitor deep tendon reflexes. Remember, monitor deep tendon reflexes, cardiac dysrhythmias given to decrease seizures and preeclampsia. Medications, methylodopa, niflupine, hydralazine, and labetalol. Low aspirin after the first trimester. Magnesium sulfate is an antidote. Calcium gluconate or calcium chloride. Intraprofessional, monitor your vital signs. Patho, expected to find severe continuous headache, nausea, blurring of vision, flashes of lights, or dots before the eyes. Discharge planning, bed rest and in the sidelining position. Diversional activities, avoid foods that are high in sodium. Avoid alcohol and tobacco and limit caffeine. Drink 6 to 8 glasses of water per day. Maintain quiet, dark environment. Take medications as prescribed. Lab findings, elevated liver enzymes, blood creatinine, BON, uric acid, CBC, clotting studies, and chemistry profile. And that, my friends, was gestational hypertension. Now, this next one is very lengthy. So we're going to do that one. And then I'm going to take a small little break. Deep vein thrombosis. Woohoo! Signs and symptoms: leg pain, tenderness, ankle edema, calf swelling, dilated veins, common sign. If the inferior vena cava is involved, both legs may be edematous and cyanotic. Also, arms, neck, back, and face may be edematous. Potential complication. Partial blockage occurs within 5 to 7 days. Clots get larger and has a tail that blocks the lumen of the vein. Can become a pulmonary embolism. When it travels through the venous system to the right side of the heart, turbulent blood flow, severe complications, PE, chronic thromboembolic pulmonary hypertension, PTS, phlegmasia, cerula duolens, swollen blue painful leg. Advanced cancer, surgical interventions, air embolism, improper placement or migration of the filter, perforation of the vena cava, device, increased VTE. Who is at risk? Smokers. Muscles are inactive, impeding normal endothelial or venous wall abnormality or damage. Anemias, fever, dehydration, polycythemia, cancer, sepsis, corticosteroids, estrogens, hormones, fluctuations, CHF, AFib, varicose veins, fractures of the pelvis, hip, or leg, abdominal pelvic surgery, trauma, protein, CNS deficiency, over the age of 35, women. Diagnostic labs, D-dimer, and/or ultrasound, ACT, APTT, INR, bleeding time, hemoglobin, hematocrit, platelet count, D-dimer elevated, normal range is less than 250 ngs over milliliters, fibrin monomer complex, non-invasive venous studies, venous compression ultrasound, duplex ultrasound, invasive venous studies, CT venography, MR venography, contrast venography, nursing interventions. Prevention and prophylaxis, treatments, rest, pharmacology, anticoagulant, surgical, venous thrombectomy, inferior vena cava Greenfield filter. VTE, prophylaxis, is a core measure of high-quality health care in high-risk hospitalized patients developed by the Joint Commission's the National Quality Forum. It addresses prevention and prophylaxis, venous thrombectomy, IVC filter. Ambulation. Change position every 2 hours up in a chair for meals and walk at least 4 to 6 times per day. Compression stockings. Intermittent pneumatic compression devices. Adequate hydration. cognitive perceptual, pain in area on a palpitation or ambulation, fever, anxiety, pain, skin, taut, shiny, warm, skin, erythematosus, tender to palpation, cardio, distension and warmth of superficial veins, edema, and a cyanosis of extremities. Carefully check dosage, monitor vital signs, have antidotes available, signs and symptoms of bleeding. Medications. Vitamin K antagonist, VKA. Warfarin begins to work 48 to 72 hours. Thrombin inhibitors. Unfractured heparin, low molecular weight heparin. Factor XA inhibitors, rivaroxaban or Exaldo, apixaban or Eliquis, indoxaban or Savolazia. Low molecular something. LMWH, enoxaparin, andadexin alpha, reverses over Abaxin and apixaban. Andexint. Interprofessional care, surgery, respiratory other treatments, venous thrombectomy, anticoagulant therapy, vena cava interruption devices, Greenfield filter. Patho background, Vircho's triad, venous stasis, endothelial damage, blood hypercoagulability, platelets aggregate, clotting factors stimulate to produce fibrin, white cells, red blood cells, and platelets, thrombus formation like edema, pain, and arrhythmia. Discharge planning, use only on electric razor. Make precautions to avoid injury. Report signs and symptoms of bleeding. The prescribed dosage at the precise time. Do not stop taking drug abruptly. Taper. Avoid restrictive clothing. Do not massage. Moisture skin. TED, soft toothbrush, minimal to no pain. No complications. Vitamin K antagonist. Warfarin. Normal is 0.725 to 1.25. Therapeutic is 2 to 3. APTT normal range 25 to 35 seconds. Therapeutic 46 to 70 seconds. Unfractured heparin, hydrin derivatives, biliverdin, synthetic inhibitors, argotropin, dabigatran, activated clotting factors, ACT, normal 70 to 120 seconds. Therapeutic greater than 306 seconds. Unfractured heparin, hydrin derivatives, bilirubin, synthetic inhibitors, anti-factor XA, low molecular weight heparin, Lovenox, normal, 0 use over milliliters, therapeutic, 0.6 to 1. Factor XA inhibitor, normal range is 0, therapeutic, 0.2 to 1.5. Fondaparinux and rivaroxaban. Foods and drugs avoid and minimize with heparin. Avoid allopurinol. Okay. Foods and drugs to avoid or minimize with warfarin. Avoid allopurinol, NSAIDs, and acetaminophen. Vitamin E, histamine blockers, cholesterol-reducing drugs, antibiotics, and antifungal. Oral contraceptives and antidepressant. Thyroid drugs, other anticoagulants, corticosteroids, herbs such as St. John's wort, garlic, ginseng, ginkgo biloba. Eat in moderation. Broccoli and Brussels sprouts, cauliflower and cabbage, spinach, kale, and other green leafy vegetables, and of course liver. Unfractured heparin. Antidote. Protamine sulfate. Notify doctor if APTT value is greater than 70 seconds. Given sub-Q. LMWH. Enoxaparin and dalteparin. Monitor CBC. Give a reduced dosage in patients with renal impairment. Antidote is protamine, and it neutralizes. Thrombin inhibitors. Biliverdin IV. No antidote. Disrudin sub-Q antidote. None. IV used for VTE prevention and joint placement surgery and non-valvular atrial fibrillation. Antidote is the IDARUCIZUMAB, Praxibend, and Debacatron for Dexa, PO. So thrombin inhibitors, that's their antidote. Factor VIII inhibitors, sub-Q is the Ponderorix. Antidote is the Antidexinet. PO, Rivaroxaban, Apixaban, and Endoxaban. So all the factor X's have X in their names. Monitors the CPC creatinine. Give initial dose 6 hours post-op. May cause thrombocytopenia. And again, factor X's antidote is the Antidexinet alpha.